All right, welcome to Project Echo. I'm Will Schmeckley. I'm a project coordinator at the Nebraska Medical Association. I coordinate this grant-funded project along with our sixth grade experts. Today, Alex is doing a talk on comorbidities of infectious medical management of infectious comorbidities of substance use disorder. That's a mouthful. I just got a text from him. He is having some computer issues. He thinks he'll be on in a minute, so hopefully by the time I get through my intro stuff, he will have joined us. This slide here just says everyone involved in this project. We have no financial relationships to disclose. Our usual funding statement: we are funded by a federal grant. That grant comes from from SAMHSA, the Substance Abuse and Mental Health Services Administration Center. Um, those federal grant funds come through Nebraska Department of Health and Human Services, and then to us at the Nebraska Medical Association, help cover our experts' time to make these trainings possible. I assume everyone's pretty much familiar now with the CME certificate process here. Just complete a quick evaluation survey and your certificate will pop up automatically. Holler at me if you have any troubles with that. You'll see a link in the chat towards the end of this meeting and then an email an hour or two after the meeting with that link to the survey. A current Echo series. So here's where we are in our list of four. We do these in groups of four. So we're in the third of four here that Alex is doing. And then in a couple of weeks, the Echo team will be doing case studies for special populations in SUD treatment. And I'm gonna stop sharing my screen to let our expert panel introduce themselves. I think we're missing a few folks today, and I know one or two are going to be joining us late. So let's see here. John, would you like to introduce yourself?
Yeah, good morning, everybody. I'm John Massey, and I am an interventional pain physician in Lincoln, elsewhere too.
Thanks. Mary.
Morning, I'm Mary Ellis. I'm an attorney, nurse practitioner here in the Omaha and surrounding community areas.
Excellent. And before I turn it over to you, Alex, I'm not seeing anyone. Anyone else from the Echo team on? I know Todd is going to join us later. Um, Stephanie and Ed, I think, are out today. So, Alex, I'm going to pass it on to you.
Morning. I'm Alex Dworak. I'm a family physician who does a variety of specialized services that my patients have needed over the years here at an FQHC in Omaha. Uh, well, I'll go ahead and share my screen here. Let's make sure this works. All right, Will, are you seeing my screen share here?
Yep, that looks good.
Perfect. Okay. So I appreciate the opportunity. And I think I have way too much material for 1/2 hour. So depending on interest, I have more material prepared, but we can, I love feedback about this. So I'm going to talk about some infectious comorbidities of substance use disorder. I've been taking care of people with HIV for over 10 years. My clinical pharmacist and I have been curing people of hepatitis C for almost that long. I think there's a lot of relevance to this. But So here's my agenda to go over some different things. Right, and then so why are we talking about this? This is about pain and substance use disorders, right? Just at the Nebraska CARES meeting, which is about taking a state level approach to eradicating infectious diseases. The word is syndemic. These things often go together. And Having access to healthcare, medication-assisted treatment of opioid use disorders, sterile injection equipment. There is again a bill that went before the legislature that I got to testify on behalf of the NMA supporting for syringe exchange programs, which have a lot of evidence that they reduce infections as well as have other benefits. And overdose prevention with naloxone, and then looking at things like income inequality, police activity, healthcare policies. These all go together with substance misuse, overdoses, and we know that substance use and chronic pain are intertwined. That's just how that goes. So, From this paper, immediate implementation of broader hepatitis C and HIV testing and substance use screening, MATs, needle and syringe exchange programs, naloxone programs, and hepatitis C treatment. And so, again, I'm going to hopefully talk about that, bring some of my expertise there that I've been given by some excellent mentors here in Nebraska. If you take nothing else away, just if you can talk to your patients and screen, and then if you, or not if, when you find some of these infectious conditions, there are pathways to get assistance with that and help your patients get better. So, and then here's a real life example. So Will Cook was the AAFP Physician of the Year because he was a solo private practitioner, not setting out to treat anything like this. He was running a rural family practice with obstetrics, private practice, hung up his own shingle, just doing his own thing. And the HIV and opioid epidemic exploded in rural Indiana, where one of the most striking things I remember from that was that grandparents were showing their grandkids how to find a vein and shoot up, and with needle sharing, opioid use directly drove an HIV outbreak. There was some hepatitis C too, if I remember right. So Will signed up for a program through Maytech, which is a federal AIDS training set of different regions. He was completing this year-long fellowship as I was starting it. So I got to sit next to him. But again, private practice, probably like a lot of you, minding your own business, just didn't sign up for anything special with this, but it came to his patients. So for my disclosures, I don't have any financial disclosures. As usual, if somebody wants to hook me up with something, please talk to me after the meeting. Like I said, I have a lot of experience with treating HIV. Sue Swindles, who is a world famous HIV specialist, was one of my mentors and pushed me to treat hepatitis C as well. I got to sit next to Will, and I was like, I knew he was cool. Because I kept reading about him afterward. I didn't realize how cool he was. Again, I was already after infectious diseases before COVID, turned the world upside down and killed some of my patients. So, right. So, Hep C, Hep B is something that we're focusing on more for a variety of reasons. Hep Delta, I'm going to review briefly, and HIV. I think that'll be all we'll have time for today. But I've got more if there's no cases and if people aren't tired of hearing me talk. So Hep C is an RNA virus. It causes chronic hepatic inflammation. There's a recommendation from the CDC to do universal screening for all adults 18 and over. And then a new, relatively recently, about a year ago, I believe, I'm not doing obstetrics anymore personally, all pregnant women with each pregnancy. So that's new. And then certain high-risk groups more frequently. Injection drug use and sharing needles is one vector. Men who have sex with men, really anal sex is a vector because there's a little bit more tissue trauma commonly, and that provides a vector or an opening for hepatitis to pass through the mucosal lining. Also, other STIs make it more easy to transmit not just Hep C but HIV. There's an explode. Douglas County here, where I practice, still has very high STI rates. And then there is a nation-leading explosion of syphilis just to our north in South Dakota, in just north of us in South Dakota. Some of the counties that are worst hit are home to a high proportion of Native American folks. These things are just facts. Hepatitis C is extremely treatable and curable. So again, the recommendations to screen all adults 18 plus at least once, so universal screening. We have implemented decision support in our EMR, which helps with that. Also, talking about it with everybody helps take some of the stigma away and normalize it. That is extremely important too. Uh, and Again, screening each pregnancy. I'm not sure if there's places where our positivity is under 0.1%. I would personally love to help Nebraska get there. Mark Malliard with UNMC Hepatology was another person who provided me some mentoring. He had a goal of eliminating hepatitis C in the state of Nebraska. He's retired, so To paraphrase Kylo Ren in the Star Wars movies, I've taken the view of I will finish what you started. So, and again, current or previous injection drug use. Most of the baby boomers have already been screened, but there may be some folks in your populations that you serve who haven't. People with HIV should be screened, and then if people have ever been on dialysis because you have blood-to-blood contact, Dr. Malliard actually helped lead an investigation that found that there was a cancer clinic in Fremont that was a source of a hepatitis C outbreak. That's an interesting story. And if anybody wants to email me or get with Will, I can point you to the documentation about that. Some medical detective work, actually. So, and then if people have elevated ALT without an obvious cause, fatty liver is extremely common. So we're going to see more of that than we will Hep C, but you need to rule that out. So. Then if their IgG is positive, that means you've had it ever. And people do sometimes clear it on their own. Once it's positive, it's always positive, and people can get reinfected. It's not a protective antibody. You're usually going to see a viral load in the millions. If you see a very low viral load, like in the hundreds or even under 100, you may see somebody who is clearing it. I have had that with a couple of my patients. If it's very low, you can repeat it and let the patient know they may be curing it, but we need to follow up on it. If their viral load is in the millions, again, you've confirmed that they have active infection, you should treat them. There's no like waiting a certain amount of time until they get fibrosis. There was a lot of nonsense with that, with insurance companies trying to get out of paying for treatment. That is not the guideline. The guideline is search and destroy. If somebody has it, treat them. There's six genotypes. They used to be a bit more important in terms of regional prevalence. Sorry. But there's now pan-genotypic treatments, so that doesn't matter as much. Even getting a genotype is another barrier, often requires another blood draw, maybe more cost. And there's a push to remove that because it really doesn't change our management this day and age. Treatment is, I believe, 98 to 99% effective. It's so effective that if somebody isn't cured, you wonder, did you take the medicine? So far, out of a few hundred people, I think there's one case where somebody's been persistently treated where we think they actually have taken all the medicine. It's a family with no English proficiency, so we've worried a bit about the communication. But again, there's also hundreds of people where they don't have it anymore. So. And then if people have ongoing risk factors, whether sex, dialysis, needle exposure, you need to use a viral load because the IgG is once positive, always positive, and kind of like a TB test. You can tell people, even if you've been treated, this is always going to be positive if they move or see a new medical team. There are some guidelines out there from the AASLD and IDSA. And again, I won't read these out. This is free. It's a living document. It's updated. It is fairly algorithmic and I think fairly easy to follow. Again, it just says here's exactly what to do and how to move ahead. There's some subtleties if someone has cirrhosis or not. Everybody who has cirrhosis deserves to have a GI doctor offered and recommended to them. And the big thing is if somebody has cirrhosis, from whatever reason, they need liver cancer screening every 6 months with AFP and ultrasound. And if they got cirrhosis in part or in whole from Hep C and you cure the Hep C, they still need cancer screening because just the presence of cirrhosis means you need cancer screening. Um, so my simplified approach to this is do they have a positive antibody? So we're screening everybody. And if someone asks for screening, if they're on PrEP or doxypep, if we're treating them with MAT for a substance use disorder, if they're on dialysis, I'm recommending screening in those situations. And then is their viral load positive? Again, about 15% of people get lucky and clear it. Most do not. And then again, we previously had to think of the genotype. That's less needed now. You're going to want to get a CBC, CMP, and PT-INR to do a FIB4 fibrosis score. I use the one on MD Calc. I mean, that's freely available. Just to figure out like how damaged is their liver. Higher ALT and lower platelets are more suggestive of cirrhosis, as is a higher PT-INR because your liver, if it's scarred, stops making clotting factors as well. And then again, hopefully we won't have to check genotypes because it doesn't matter. treat the patient, and then check for sustained viral response 12 weeks. And then again, virus dead, patient alive, liver happy, clinician happy. And then again, as a reminder, if they have cirrhosis, you need to keep monitoring them for development of cancer. So, so I saw a couple things in the chat. Let's see here. Okay, and it looks like that was about some other stuff. So, okay, and yeah, I would say we do save an awful lot of money. Liver failure is very expensive to treat. Kidney failure is very expensive to treat. Advanced HIV is very expensive to treat. Lots of, I mean, yeah, an ounce of prevention is worth far more than a pound of cure. So I will keep trying to look at the questions. Please feel free to throw those in the chat, or if you want to message Will and just unmute, I'm fine with that too. Uh, but so there's some national report cards about the state of hepatitis C access, especially as regards Medicaid. Many of the people who have these risk factors are also living in degrees of poverty. That's how this tends to go. And so a thing that happened recently that I and some other folks, including Dr. Balasanova, a fellow NMA member, Dr. Netta Fadul and Dr. Sarah Bears, infectious disease specialists that I am fortunate to work with at UNMC. All of us advocated to get the sobriety requirement removed because we had people who were smoking marijuana and had hepatitis C and we couldn't treat them. And we're just like, you don't pass hepatitis C with weed. That's like, yes, we'd love everybody to quit, but this is dumb. And even if someone's actively using drugs and injecting, uh, that's actually a really high priority population to treat because you can use treatment as prevention. Those are the people who are most likely to pass hepatitis C to somebody else and cost more money. So thankfully that was removed, and so our grade got better. And also this fibrosis requirement, this is like you have to be sick enough to get treated. That is not only silly and not per the guidelines, it's also psychologically very stressful for patients. I have multiple patients whose mental health was very negatively affected by knowing they have this disease, feeling dirty, dealing with stigma. One of my patients, a black woman, talked about lots of stigma and being accused of having dirty blood and stuff, and it really affected her mental health. So uh, there are multiple reasons to just find this and treat it, and thankfully we're getting closer to that. So our grade is a C, it was an F, so we're making progress. And I have had to fight with this prior authorization thing where they're like, "Are you an infectious disease specialist or a hepatologist?" And my response is like, "So my clinical pharmacist and I are both HID clinician scholars. And how many people have you cured of Hep C again? Insurance person? None? Okay, great. Well then, what are you doing?" And then substance use counseling, that's always helpful, always recommended, of course. But again, having it as a barrier isn't helpful. And if someone's actively using substances and actively has Hep C, those are actually some of the people that it makes the most sense to cure because that's how we get to zero cases. Transparency and parity across the MCOs and other organizations. Yeah, just like, what do we've all had this experience, I'm sure, of like, well, it's denied. Like, well, why? Well, we can't tell you, or reasons basically. And you're sitting there like, you're practicing medicine without seeing this patient. I'm personally responsible of them emotionally, ethically, and medical, legally, and fiduciarily. And you will let me do this thing that all the guidelines agree is a good idea. Like, why? So, again, just in general, making it easier for not just specialists here in Omaha to treat this is what's going to have a benefit for the state and save our state budget lots of money. If even if we care about nothing but money, this is a good idea. So, okay. Any questions about Hep C? Just basically find it and kill it. And if you do have that, I would be happy to talk to people. Will can get you in touch with me. The Specialty Care Center, aka HID Clinic at Nebraska Medicine, does a lot of consulting across the state, and they may actually be able to come out and do a lecture for you if your group would like that. I would be happy to talk about trying to do that too. Again, this is something that if we're all in it together, we have the ability to completely eliminate this virus. Like, it doesn't stand a chance if our state is all pulling together in the same direction. So. Okay. So Hep B, quickly. So it's a DNA virus, not an RNA virus. It also increases chances of cirrhosis and liver cancer. It's vaccine preventable. And I think if we take one thing away from this, especially on our immigrant patients, but really everybody, making sure that people are immune and then revaccinating or vaccinating for the first time if needed. Again, this kind of like the HPV vaccines, this vaccine is cancer prevention. And I think it's important to point out vaccine hesitant or frankly anti-vaccine families may not have vaccinated their children. And so you might see somebody who, talks like somebody who grew up in Nebraska, like me, where you think, oh, they're probably immune, and maybe they're not. And they may be open to vaccination, like, because again, this happens when they're kids, or maybe they're still not. Again, it's going to be individual. And then some people won't retain immunity despite having been vaccinated. So then this is an excellent program that is through the University of Washington, and it also has some CDC funding here that I put in. And That's a webinar you can go through for extra CME credit if you'd like. But the main takeaway is screen all adults at least once for Hep B in primary care. So also, if you're practicing in a specialized addiction setting, either talking to their primary or screening them yourself, and then linking them to care if like if you can't vaccinate, getting them a primary. If you diagnose Hep B, getting them linked to care. Again, just if this can easily go undetected for a long period of time, by the time it makes itself known with something like clinical manifestations like jaundice, the cat's out of the bag. Uh, and then just a little bit of background. Almost 1 million people in the United States have chronic Hep B infection, which is more than I would have thought before I got this slide ready. And then Many countries in Africa and Asia, the Pacific Islands, and some parts of South America have vertical transmission, and that's where most infections are here. And then Similar to other bloodborne diseases, injections, drugs, men who have sex with men, or penises and rectums. And then If you have HIV and you're immune suppressed, that also increases your risk, and that can go together. I have patients who have HIV and Hep B and who had Hep C, all from substance use. And then household contacts, so sharing razors, toothbrushes, it's important that if we diagnose one person in a household that we offer screening to everybody else. So, and there's some links to AAFP as well as where I got these pictures from because I didn't make them. So. And Most people who have chronic Hep B don't know it. It's asymptomatic. And again, if we wait till it becomes symptomatic, they have cirrhosis or liver cancer, and that's bad. So they can also be transmitting this vertically or otherwise that whole time. And Again, 15 to 40% of people with chronic infections, so not everybody, but way too many will again have extremely expensive, life-altering, and life-ending complications. So. And then This was from the University of Washington, which again is an excellent resource for all things hepatitis. And just looking at some of these countries, a lot of them are in Africa and the Pacific, and one in Central Asia there. They are mostly populated by people of color. A lot of them have had colonial influences, and so I'll just, again, that's just facts. So, uh, and here's a map that just kind of highlights things. We do have a lot of immigrants across greater Nebraska, here in Omaha and as well as in greater Nebraska from many of these countries. So again, this even if we're wherever we are in Nebraska, this is something that I think merits our concern. So. And then found some things here about just who is here in Nebraska. So we have several thousand, well, actually several tens of thousands who were born in countries outside the United States, where they're, again, a higher priority to screen. But people who grew up here in the United States, again, may or may not have been vaccinated, may or may not have retained their immunity. And this is certainly not an immigrants only phenomenon. And then just going through the rest of these things here, keep us moving. So again, University of Washington has a ton of free information. They're an excellent resource, and I want to make sure I included that. And if you're interested in learning more, that can't recommend that highly enough. So, briefly, in the next couple of minutes before we see if there's cases and decide if we forge ahead with HIV or not, hepatitis delta is a satellite or defective RNA virus which needs Hep B to replicate. If you can't get Hep B, you can't get Hep delta. So again, vaccination protects us from this too. It's kind of a Hep B plus where things get worse than hepatitis B by itself. And it's a lot of the same risk factors will apply, of course, and then more common in areas outside the United States. But again, people travel, people immigrate, people may, do high risk things while they're on vacation and come back. So it's something to be aware of. This is one reason among many why, although hepatitis C is very appropriate for primary care, in my opinion, Hep B deserves somebody who specializes in it, which could be a primary care person. Most of the time, that'll be an infectious disease or a GI specialist. The treatment decisions are more nuanced, and so people deserve to have specialists recommended to them, and hopefully they can get to it. So. And then there's two patterns. I've not personally seen this, but if there's co-infection where you get both at the same time, that tends to be very bad, and people often die. Super infections where someone's had Hep B for a while, and it may be in the immune tolerant phase where they're just kind of cooking along and the virus is replicating but not causing a ton of damage. Then they get Hep D on top of that. That's still worse, but getting them both at the same time is really bad. So. And then there's a little bit of back and forth between different specialty societies. This is where, again, I think for the vast majority of us who aren't liver specialists, getting a liver specialist involved is a good idea. Okay, so I saw a couple more things in the chat, and I think we're at a good spot for me to pause. So yeah, well, and again, I have a great passion for these things. I got a lot of mentoring, and I want to pay that forward. So, if anybody is having stuff come up here, I would love to talk to you. And then, Hep B, if you're asymptomatic, do we need to screen before vaccinating? I think that's a great question. I am ordering. So my usual panel is Hep C or Hep B, surface antigen, surface antibody, and core antibody. That will tell us does somebody have infection or immunity. And so I would recommend that just because if you don't screen them and you vaccinate them, but they already have chronic Hep B, that won't do any good. So it wouldn't nothing bad will happen. But we may miss a diagnosis, and the patient may think they're protected, and they're not. So, and again, the our lab core that I use here at my FQHC has a little algorithm to interpret it. It can be occasionally be a little bit kooky, but getting core antibody, surface antigen, surface antibody. Something I like to trick my students and residents with is asking them what happens if the surface antigen and surface antibody are both positive at the same time. That shouldn't happen because they complex with each other, and so whichever one there's more of should be the only one positive. But again, I would grab those three tests as part of your screening because it can make sure if somebody's already immune and doesn't need it, or if they have an infection. And I'm trying to work this in on my like wellness visits. When somebody comes in, they'd like to get checked out and make sure they're doing okay, like screening for diabetes, cholesterol screening, talking about exercise, that kind of stuff. And then definitely my patients where I am giving them PrEP. And there's some nuance with HIV treatments and Hep B that I'll talk about if we have time. And I try to do that with my MAT patients who we're seeing for Suboxone. A lot of them are fairly skittish about getting blood drawn. Not all, but I had one person who came in and said, I would like Suboxone and I would like hepatitis C treatment. And I was like, say less, let's do this. But when patients with substance use disorders develop enough rapport to let me draw blood, I'm trying to incorporate that there too. So. Well, do we have cases? Do we want to give people a chance for that? Again, I've got HIV plus some more stuff about syphilis that I know we have more than we have time for. But I'd like to use the time however the group would like, or however would be best.
Yeah. Yeah, absolutely. Yeah, so if any cases are welcome. any further questions on any of the things Alex has covered so far, um, feel free to drop those in the chat, or you can raise your hand and speak up if you'd like. I'm not seeing anything come in.
Well, that's about all
So,
the encouragement I need. So,
okay.
uh, okay, well, since you've had a chance to speak now or forever hold your peace, well, not forever, but for the next 27 minutes, let's forge ahead with HIV. So, okay, so HIV, which I've already touched on in one of my other talks, is an RNA retrovirus which spreads again via sexual and blood routes. Acute infection can make people have lymphadenopathy, fever, and just generally not feel well. You can have a nonspecific rash, but again, a lot of times people are asymptomatic and may not know their status. There's less stigma these days, and more people are knowing their status, but there are still persistent disparities there. And there's a lot of social factors that go into that. So, advanced HIV or AIDS, if you have an opportunistic infection, that's an AIDS-defining illness, and often weight loss and muscle and fat wasting. I mean, the slim or skinny disease can be different nicknames for it, including outside the United States, where somebody looks cachectic and like everybody knows, like, oh, you have HIV. So. Uh, Reverse transcriptase enzymes allow for viral replication as well as integration into host DNA. And that's why HIV is, unlike Hep C, so difficult to cure. Hep C only lives in hepatocytes, same for Hep B. Hepatitis C is uniquely curable. There's no reservoirs for it. HIV does get into our DNA, and it also gets into immune sanctuaries like the central nervous system. That's part of why it's incredibly difficult to cure. The good news is it's very controllable, and there's ongoing research looking for different avenues for cure. But even if we stopped here and we never could cure it, you can have HIV and live a normal life. But we have to know about it, and people have to be connected to care and be able to get the care. So. Okay, so again, condomless sex, and again, other STIs that cause some tissue damage kind of open the door and make HIV easier to transmit. Harmful use of alcohol or drugs in the context of sex, that's much more common than we might think. Sharing injection rigs and such, unsafe injections, which could be tattoos, which could be body contouring and fillers. Which could be, trans folks modifying their bodies. It could be cisgender folks, like injecting synthol and oil, like to look like more like bodybuilders, tissue transplants, and then unsterile medical procedures or needle sticks. Needle stick is very low risk for getting HIV, actually. So it's something that's worth mentioning, but the vast majority of us, even people like me who do procedures and surgeries, are not really at high risk from that. And this is all from the World Health Organization. So risk of HIV transmission through vaginal sex. In general, the receptive partner is always going to be at the highest risk, more than the insertive partner. But vaginal sex is less risky than anal sex. Again, the mucosa are different, and the tolerance for friction is a little different. I don't have that in here. I could find that pretty quickly, but receptive anal sex is always going to be your highest risk. And again, that is something that people with vaginas can have too. And then vaginal sex, and then insertive, sex, the penis haver, is at lower risk of acquiring HIV. Then oral sex is incredibly low. Again, I think it would almost be like a case report if that happened. I mean, it's almost always genital sex. So, great question though. And Again, just we know that HIV has differential distribution. Black and Latinx folks have higher rates of infection. The South has the highest rates, and those are starting to come down. But men who have sex with men, trans women have much higher rates than straight people, but straight people can get HIV too. Diseases don't discriminate. And people who use drugs have higher rates. Again, both from sharing needles and also whether it's injection drugs. or alcohol. Nebraska's national or state drink is Busch Light, I think. Every time I've gone to see my relatives out in greater Nebraska, there's been a few suitcases of that around. So people do riskier things when they're under the influence, and it doesn't have to be a bloodborne thing like heroin or meth or anything like that, although that'll do it. Beer will lead to riskier sex behaviors too. So, and then also because we can't have nice things. Coercion and non-consensual things are a fact too. I do have patients who have HIV, and there can be a lot of stigma even among, what we think in our minds, like, oh, this person must have been doing X, Y, or Z. I have people who were sexually assaulted, and that's where they got their HIV from. So, which has as many mental health effects for them as you would imagine it does. So, just trying to be trauma informed, especially when talking about these things, is you're never going to go wrong doing that. So. And here's new cases, and so you can see we're here in the Midwest, where we're fairly low, not as low as some of the Caribbean, but the South, 52% of cases. That's not where 52% of the population lives, and so again, that's a disparity. And then here's a heat map and you can see Nebraska doesn't have a lot of this, but actually, some areas here in the middle of Nebraska are as high as they are here in, the STI capital of the Midwest, Omaha, where I am. And then out here by Scotts Bluff. So again, this is a statewide concern. Nowhere near as bad as many of a lot of the Sun Belts down here, though. So. Okay, and then did I go backwards here? Or I'm just bad at editing slides. So, and then as I was talking about HIV prevention with a black medical trainee taking care of one of my trans patients, I went to show her the guidelines, and this popped up, and so it's like, okay, this is our current reality. So, I'll just leave that there. Um, so we did see some decreases in the last few years among Black folks, but we're not to parity yet, and people of color are still dramatically overrepresented in terms of new infections. And so if we believe that that's unjust, then that's a call to action. So. And then the folks who consistently have the worst of it are Black trans women. The first person whose HIV care and hormone care I ever owned was somebody the Dr. Swindles had been taking care of, and she entrusted me with this woman's care. She was a Black trans woman who had HIV and high blood pressure. And who smoked and faced a lot of discrimination. Like all those things are the fact that they literally were present in her body at the same time were not an accident. And tragically, she was a few years into my care of her murdered. She was shot, and that also is sadly not surprising. Again, these things are facts, and we can either ignore them or say that's a thing, and I would like it not to be a thing, and what can I do about it in my own little corner of the world here? So. So for prevention, PrEP has been absolutely amazing, and I think I mentioned this in my talk about pregnancy. There's two pill options: tenofovir disoproxil fumarate, TDF FTC, brand name Truvada. I don't own stock in any of these companies. Tenofovir alafenamide emtricitabine, or TAF FTC, or brand name Descovy. For most folks, we're using the newer one, Descovy. It has a little bit less toxicity. If somebody has a vagina that they have sex with, the older one is recommended. So just, explaining that the tissue concentrations aren't thought to be as high and we don't have as much data, and making a recommendation that's non-judgmental is my best recommendation for everybody. So. Then there's a every 2 month injectable option, cabotegravir, which is very effective. But it is something that has a bit of nuance because the fact that you can inject it every 2 months, it lasts for a long time. And it will enter the subtherapeutic kind of tail period where there's enough of it around to piss off the virus, so to speak, as Dr. Swindles used to say, but not enough to treat. And you can, if you acquire HIV during that time, whether you fall out of care or you decide to go off PrEP, but then you are exposed to HIV, you run the risk of acquiring HIV that's then partially treated. HIV always needs multiple things to treat it. This is only one, so we're half treating it. And this may not show up as an obvious infection. It may be more smoldering than an explosive, and your labs are going to be different. So, yeah, I know that there's some folks who don't necessarily specialize in HIV who are looking at cabotegravir. It can be a nice moneymaker. Patients like it. There's a lot of good things going for it. You have to do your homework and know about the lab monitoring because it can be tricky to catch HIV in that setting. So if people are interested in cabotegravir, I'm not saying don't do it. I am saying you need to, if you're a provider, you need to be really knowledgeable, quite a bit more than you do for the PrEP pills. That's a lot more straightforward. Uh, and then hopefully this summer, so lenacapavir, which is a capsid inhibitor, which helps stop HIV getting into cells, is already approved for treatment, and it can be part of salvage treatment for people with multi-drug resistance. But it's every 6 months subcutaneous injection, which may take PrEP even further. Again, that's likely to be approved this summer. I actually just talked to somebody yesterday about is there a tail period with that, and they referred me to some studies that I haven't had a chance to read because that was yesterday at 4 p.m. and then my daughter had a band concert last night. But That's pretty exciting. And cabotegravir is a big IM injection. Well, like you're going to feel that. Again, the lenacapavir is subcutaneous. It's closer to an insulin injection. And again, these things give us the ability to stop HIV in its tracks if we have the political and economic and societal will to get everybody who needs access to this access to it. The vast majority of people on PrEP, including even here at my multilingual FQHC, are cisgender white men who look like me. But that's not the vast majority of who is getting HIV and who is at highest risk. And that's even in a place where I see people in Spanish, and we're trying as hard as we can to overcome those barriers. Even here, those barriers still exist. And then rural folks are at unique and elevated risk too. I just heard some data yesterday at the HIV Update conference that Nebraska Medicine puts on, talking about rural folks. And so a lot, even whether we're in Greater Nebraska and see people of color a lot or not, this is something for all of us. And then again, if you want to learn more about prescribing PrEP pills, I would be happy to help you with that. The Nebraska Medicine HIV Clinic can do presentations on that. They have some grant support for that. Please reach out. It's very rewarding. It leads to good discussions, tailored risk factor reduction, breaking down that stigma, and again, it's also people come back for follow-up visits with it, so it's not like it's a bad business idea. It's just a good deal all around. So, okay. So we actually got to syphilis faster than I thought. So, does anybody have any questions about HIV? I'll stop here and drink more caffeine and give people a chance to. And I'll find some information about the transmission through different exposures, like different sex acts and needle exposures and stuff, and get that sent to Will. Clint, I'll get that to you, and if anybody else would like it, we'll can send that out, I imagine.
Not seeing any further questions right
Everyone into
now.
silence. So, okay. All righty. Syphilis. So, syphilis? Yes, syphilis. So, this is from a SAMHSA letter, which is fairly recent. Congenital syphilis cases are going through the roof, and that is happening mostly outside of urban areas. Although we've seen one case that my midwife colleagues have run into here in Omaha, I think. And again, syndemic is the word of the day. Substance use disorders, mental illness, chronic pain causes mental health effects. Other STIs like HIV, gonorrhea, chlamydia, they represent a syndemic. Syndemics happen when two or more health conditions cluster and interact within a population because of social and structural factors and inequities leading to an excess burden of disease. Again, like this is I've presented the facts about that. And then substance use preventionists, substance use treatment providers, so all of us, sexual health service providers, I think that includes us too. Supportive services folks, so organizations like Nebraska AIDS Project, of which I am an immediate past board member, love them, and others. Again, this is all hands on deck interdisciplinary approach. So, And then meth use. If Busch Light is our state drink, I think meth and is right behind marijuana for our state drug. It's the most common one that I've seen in my career in the clinic and in the hospital. Although these days everything has fentanyl in it, including the meth. But substance use leads to higher rates of STIs. And then pregnant women with syphilis, substance use is nearly twice as high among those with a congenital syphilis outcome than those without. So substance use disorders have this interplay with infectious diseases. I think, that's not surprising when we think about it. And then as I mentioned, American Indian and Alaska Natives, especially here in the lower 48, new syphilis cases are nearly 4 times the rate of white people as of 2020. And again, this is 5 years out of date now. And it's also increasing among gay, bi, and other men who have sex with men. That may be more common than we think of. I mean, but this impacts a lot of straight people too. But again, diseases don't discriminate. They'll infect anyone. So, and this is from a letter from SAMHSA here. And then opioid treatment programs play an important role in addressing the syphilis syndemic. So again, all of us who are treating chronic pain and substance use disorders, this is for us too. And if you're not a primary or sexual health provider, again, knowing your local network and referring people. If like me, you are primary care, then the patient is the patient is our scope of practice. So this is for us to get after. And then formal OTPs that do methadone need to be screening. And again, if you have one of those near you, you may be able to be a referral source if you're not the person who's running that show. If you are the person who's running an OTP, like I know I have at least one friend and fellow former resident who is now in charge of one of those, just knowing who you can refer to is a good deal. And whole person care sounds, yeah, what an idea. So, okay. And then there's a list of resources here on the SAMHSA site link. So to go along with the UW and the Hep C guidelines and all the other references I've thrown at everybody. Again, this was written by this PhD who is currently no longer in the job. Hopefully when that position gets filled, that person will share this enthusiasm to tackle this which again, by congenital syphilis impacts literal babies who are our future in this country. And so I hope we can all be on the same page that that's bad and let's prevent that. Uh, Screening. We should definitely think about screening if people are coming in and saying, I'd like to talk about PrEP or Doxypep. If somebody already has another infection like HIV or like gonorrhea and chlamydia. Something I learned in residency and that I tell all my trainees, if you're at risk of one STI, you're at risk of all of them. Oftentimes people screen for gonorrhea, chlamydia, and not think about syphilis. Please screen for syphilis too. And then, interestingly, persons with incarceration, okay, sex work, that makes sense. Military service. This is something that is important if we have veterans in our care. And we should be aware of how common it is. I believe Pine Ridge is still one of the highest prevalence rates in the entire United States. So that's right next to Nebraska. So I think all of us should be mindful that the risk is currently elevated here in the heartland. So, and there's some USPSTF recommendations here. This is not just my opinion. So all pregnant people should be screened, and I believe this is screened during the first trimester and the third trimester now. So those of you who practice obstetrics, that's something that hopefully you're already doing. Treatment safe during pregnancy and congenital syphilis, again, is bad. So we should be aggressively trying to prevent that. And then again, from the USPSTF, certain racial and ethnic groups are disproportionately affected, including Black, Hispanic, and Native American and Alaskan Native pregnant people who are 8 times more likely to have babies born with congenital syphilis. Again, I think that sounds terrible, and we should all work together to stop that. Again, social and structural factors. This is not, I think we all know that anytime we're like, well, that group is more prone to this because of their like moral character, whatever, like that's let's not think like that. That is not a ethical way to approach this. And then this MDMPH individual is saying 90% of cases could have been prevented with timely testing and treatment. Again, congenital syphilis has lifelong impacts. And so this seems like a golden opportunity for us to all be working together and again, this is something that we can eradicate, kind of like Hep C. Like it's within our power to destroy this. Let's channel that in good ways. So the recommendation, there's a lot of lab options here. There's multiple ways to do this. Reverse screening is recommended, where you'll do an antibody. So there's two things. There's an antibody which is positive or negative. Once it's positive for life. And then there's the treponemal non-specific treponema pallidum of syphilis, where it'll go up and down by factors of two. So there's some lab nerdery that I won't get into for time about why one's better than the other. But if you have a positive syphilis antibody that's positive for life, kind of like Hep C and other things like chicken pox, and patients may see this in their portal, and if they've already had syphilis and they don't realize it, they might think, "Oh no, I have it again." It's like, no, you once that's positive, it's positive forever. As the other one, which is an RPR or a VDRL or some test like that, goes up or down, you have a fourfold increase, which indicates new infection, and then a fourfold decrease, which will indicate cure. That can take 1 to 2 years, and it often takes longer in people living with HIV. It is also good to screen people annually if possible, and that because that helps you know if it's early or late latent, and the treatment is more involved if you don't know how long somebody's had it. And then a question on syphilis treatment to newborns regardless of parental status. Didn't see that. I could try to check on that. If you have unknown parental status, you'd want to check baby. I mean, at that point, they already have it. I I didn't see that in the USPSTF recommendations, Linda. So, uh, well, then again, I do not get any money for saying this. Sarah Bears and Nikki Reagan have come to One World and talked about this. They have an outstanding presentation. They're extremely smart. They're great speakers. They're very collaborative. If you would like to have an expert talk set up, again, they have some grant funding to support them teaching on this. Please let me know. I will hook you up with them if you want to have them come out to your group, your hospital, whatever the case may be. They're just wonderful resources. We're extremely lucky to have them. They're nationwide or national recognized researchers too. So we really have some incredible resources in Nebraska that really punch above our weight in terms of how populated our state is to help with these things. So. Okay, and then parenteral penicillin is what you want to do. Okay, Aaron, Will, I don't know if you wouldn't mind taking notes there to help me with that. Yeah, I would love to do that. So, penicillin is what you're going to want to use. There was a shortage, but that has been resolved when I checked to get this presentation ready. For a while, if somebody wasn't pregnant, we were using doxycycline instead and saving the penicillin for pregnant or possibly pregnant people. If you have a diagnosis, your local health department should be able to help you with it. If you can't find them, again, Will can put you in touch with me. I'm happy to help. Again, this is entirely treatable if we catch it. So, and here's some references from the CDC about this. So, and then this, as far as I know, is still online. I don't think that Elon Musk and his chainsaw have got to it, although we'll see. The CDC has this national network of STD clinical prevention training centers, and you can ask for an online consult. I've got that there. And then our friends at the University of Washington have some resources yet again for self-study. But really, if you take nothing away, screen people, or at least think about it and talk to them about it. And then if you find a result, whether it's obvious or if you're like, what does this mean? I don't know where to go from here. Ask for help. There's lots of help. And then, if you're screening people, you're going to be doing a both individual and public health good, and literally fighting injustice. So that's cool. Okay, and then this is from University of Washington here, just talking about the different stages. This is why having a negative test last year in the bag can be nice to know exactly where we are. And then rarely you'll have neurosyphilis, ocular syphilis, or otosyphilis. if you even think that they might have a focal neurologic sign or anything else, or like their vision's off or their hearing's off, like you get an infectious disease expert involved, like reach out for help. That is more involved and more dangerous. That's rare, thankfully. And again, I won't bring us all back to our first year of med school going over this, but again, there's a lot of resources out there. And again, if the main thing we can do in primary care and addiction and pain management care is help people get screened, and then once you find it, you can always go look it up and ask for help. But it's really screening people that is the major way we can have a good impact. So. Okay, and then like I said, this is something the NMA has taken a position on that aligns with the American Academy of HIV Medicine, American Society of Addiction Medicine, the American Psychological Association, the AAFP, all the major medical societies. Syringe exchange programs are helpful. Getting clean needles helps, and it's also a touch point. I was really moved by one of the testifiers at the hearing that I went to, where he said, at one point, I was using 600 milligrams of Oxycontin a day. I hated myself. I was not in a good spot. If I had had one of these programs where I talked to somebody who gave a damn about me, maybe I would have gotten out of my addiction sooner, and maybe some of my friends who died would still be here. I mean, just that's if that's not a mic drop moment, I don't know what is. And so that's another way that these syringe programs can help. But again, we are in a situation nationally where some of the gains we made in HIV prevention and slowing down the epidemic are at risk. Our progress towards getting where we want to be with less of these infections that are heavily associated with substance use is in some jeopardy. Hopefully Nebraska will get that on the books and communities will be able to decide how they want to do that across our great state. And that can be another way we chip away at this rather than just letting the infections run wild to do what they will. So. On that note, it's 8:29, and I can't believe I've talked this much with so few pauses to drink more caffeine. I really appreciate everybody's attention and the questions. Again, I have an obvious passion for this. I hope my passion's obvious, and you don't have to be an infectious disease expert to make a big difference with this. So again, thank you all so much for your time and your attention.
Thank you, Alex. Really appreciate it. Ton of good info in those slides. I'll be sure to send those out in an email later this morning. Along with that email will be a link to that evaluation survey to complete that real quick and get your CME certificate. That link is also in the chat here. We'll be back in a couple of weeks. The Echo team, including I think Alex, Mary, and Stephanie, are doing some case presentations on special populations. So be sure to see us again in a couple of weeks for that. Thank you. Oh, and then Echo team, if you guys want to hop over to that other link for a quick team meeting, we can do that now. Thank you.